So I got a few questions for you, Nick. It's my understanding that Cigna and Anthem agreed to remove prior authorization requirements for medication-assisted treatment in response to the Attorney General in New York in their parity investigations. So if Cigna and Anthem can agree to remove these barriers, why do you object to prohibiting authorizations here in California?
This bill is not limited to medication-assisted treatment. This bill includes all substance abuse-related disorder drugs. Mm-hmm. So, I mean, and also that's the first I've heard of this, so we will look into that, but this bill is not limited to MAT.
Okay. It even says on the website, if prohibiting prior authorization harms patient safety, why does Cigna tout on its webpage that to save lives as a part of the opioid crisis that it removes prior authorizations? So, you know, I've been a pharmacist now for, I hate to admit it, 38 years. I don't know what the time went. And I've always had problems with prior authorizations. It kind of drove me from retail pharmacy to go into compounding and just deal with cash customers instead of insurance customers, because I was spending 25% of my time dealing with pharmacy technicians or people that weren't knowledgeable about the drugs. I had to call on behalf of physicians. In a letter that we got from the County Behavioral Health Directors Association of America, CBHDA, they claim that 1 in 10 Americans seeking a medication for addiction treatment are able to access the medication-assisted treatment largely due to utilization management policies that impose significant obstacles. So we have an opiate crisis, and it's exacerbated by having opiates that claim to be one opiate that aren't that opiate. They're actually another opiate. And I'm referring to heroin versus fentanyl. We have a fentanyl epidemic in this country. And I've had 2 family friends that lost their children to overdoses of fentanyl, thinking that they were being treated with, or they were utilizing what they thought was heroin. One of them had been through a program, methadone and buprenorphine, and failed. I've always seen prior authorizations as a way to more than question the efficacy of a doctor's desire to use a particular drug, the insurance company's obsession, if you will, with saving money. And it comes down to the question, what is a life worth? You know, you talked about naltrexone. It's funny you mentioned naltrexone, because when I was an intern at USC School of Pharmacy, we had externship programs, and I was interning at Rancho Los Amigos Hospital. And the head of the treatment center there, he gave every student that came through a drug that they had to research that was in progress of being approved. And funny, it was naltrexone that was my drug. So I became intimately involved with naltrexone over 36 years ago, and learned what a incredible drug that is. As you know, it's related to naloxone. It occupies the opiate receptors. Had our friends or our family, if their kids were on naltrexone, they would probably still be alive today. Now, I understand that, you know, sustained release naltrexone is not a cheap injectable. You know, you're looking at $1,300, $1,400, $1,500 a month. You know, I go back to hepatitis C. You know, we had a new drug that came on the market quite a few years ago called Sovaldi, right? If I'm not mistaken, I think a number of the health plans required a prior authorization for Sovaldi. Why? Not because it was efficacious in curing hepatitis C, but because it was costing tens of thousands of dollars for a treatment. So, you know, then you compare the cost of, well, if we put people on interferon and another drug to treat their hep C, they're ultimately going to have a liver transplant, which is going to be $500,000, and then they're going to be probably on $1 million worth of anti-rejection drugs. And so I have a concern that the patient's best interest is not always first and foremost when it comes to picking medications for their treatment. And I really get upset because we talked about before in the last issue the importance of a doctor-patient relationship. And I don't think that a technician on a telephone line, when I've got to call and get a drug that this doctor claims is unique and important for this person, should not be granted to be used without going through multiple barriers or bureaucracy within a health plan that sometimes take days to accomplish. Now, I can understand if you have a brand name and a generic. I am 100% in favor of generic substitution wherever possible. Or if you have multiple pharmacological classes of drugs, we got Sovaldi, we got a few others now, you can make your best deal with whatever company and get your rebates and lower your costs for your insurance companies, but the patient is going to get a state-of-the-art medication. I think what we're saying is that we want a state-of-the-art medication, and compliance is very important to treatment of people that have opiate issues. And they can't have delays, and they can't have barriers. And yes, you know, as we see new treatments come online, premiums may go up. You know, I'm sorry that premiums are going to go up $31 million, but you know what? If it's my son or my daughter that's got an opiate addiction and their doctor feels that their medication should be a costly medication that could save their life instead of using something that they could potentially fail with, and as they fail with that, the tragic side effect is they could die. So we need to embrace a state-of-the-art therapy for these emergency situations when you have people that come to us that want to get help. You know, that's a big step, sir. You know, and I want to applaud you for you seeking help and turning your life around. I don't know if you were started out with step therapies, or were you immediately put on something like Vivitrol, and how did you manage your success?
So I actually had to fight to get on to medication-assisted treatment. It was very hard for me to get on this last time, and I'm grateful that I was able to get on it because it saved my life. But I think it's really important, I try to keep my emotions out of these hearings and when this comes up, but I have personally stood over the graves of 26 of my friends in the last 2 years who have died from overdoses. 2 years, median age, we're probably talking 23, 24 years old, good kids, people like sons, daughters, employees, they all wanted help. A lot of them were, the number one story coming out was my insurance company, my kid's insurance company or my insurance company won't pay for treatment. And they cannot get treatment because of the barriers that still exist. And that is wrong. And I understand, we get caught up in the cost. And I hear from insurance companies that it's going to, then they're going to put the cost onto consumers, and you're talking about $31 million. That there is, I believe there is no cost that makes a justification for just the people that I've buried in the last 2 years. It is wrong. And as a person who is on the front lines watching this, I'm so sick and tired of hearing that argument as a justification to putting up barriers to treatment. Like, that has got to stop.
Well, thank you, and I appreciate your answer. And then I'd like to respond also. I have a great deal of respect for the California Chamber of Commerce, and I understand that some of these big plans are members of the Chamber. But I'm going to quote from the Chamber's letter that the higher priced drugs not providing benefits commensurate with the costs. Since when does the Chamber understand, pharmacology, medical benefits better than the physicians that are writing for the prescriptions? I mean, I'm just outraged that they can make a comment like that. They can oppose it. Certainly, they can oppose it, but don't question the professionalism of the physician that's doing the best they can to provide the best therapy for their patients. it looks as though that cost seems to override clinical evidence efficacy when these formularies are made. And I certainly understand the benefits of to the insurance company of doing that. But if we have a drug, and probably when you see the higher tier drugs on formularies, in most cases, they're very unique. They have very specific pharmacology not found with any other drug.
Understand.
There is no generic substitute, and they provide usually a quicker, higher quality of life and provide healing and treatment. And unfortunately, those are the drugs that have the highest copays, and those are the ones that are the hardest to get from the insurance companies because of this bureaucratic maze of getting prior authorizations that, sometimes take not days, but sometimes takes weeks to get.
I understand. I hate to interrupt,
Yeah.
but I just want to be a little conscious of
I'm almost
the
done.
time, and I realize I'm probably the last person to bring it up with you, but
Yeah, I appreciate that. So, yeah, it is getting a little late. Yeah. I'm surprised I know anything other than saying thank you, thank you, thank you. So I'll just cut to the chase. I think it's very important that we remove barriers. And other insurance companies, Cigna and Anthem, have recognized that with this classification of medications for people that have opiate or substance abuse problems, we have some good medications out there. Yes, they are expensive. I understand that. But we have a growing epidemic, and my literature shows that 1 out of 10 are successfully getting the medications that they need. And even physicians are reporting difficulty, like 41%, and having challenges in getting their prior authorizations through and getting them approved. In some cases, the patients just completely abandon the effort of trying to get the drug because it's such a problem. So anyway, Nick, I know I threw a whole lot at you, and I know you're here to represent your client. But what can we do to ensure that when somebody has an opiate problem, when you got a parent that's got a child and they don't know what to do, and we've got these great drugs on the market, but we've got to break this bureaucratic morass to get them the drugs that they desperately need and deserve.
We have an oppose unless amended position on the bill. And so I think if we are able to retain the ability to use a generic instead of a brand, which the bill in its current form does not allow, that would go a long way. And in the very limited cases where there is an important clinical reason for us to review the approval of the medication, for instance, a drug interaction which can kill the patient, things like that, then I think that would go a long way in addressing our concerns. So, our position's not just cost-based. So, again, we're opposed unless amended. Thank you.
I appreciate that, and I've known you to be a professional lobbyist here in Sacramento in the short time that I've been here, and I would strongly encourage you to work with the author, especially with the generic substitutions. And this is why we urge patients to not only use their doctor, but also choose one pharmacy, whether it's an independent pharmacy, a CVS, or a Walgreens, so we can monitor those drug interactions to make sure that we're protecting the patient and giving them the most holistic care that we possibly can. Thank you, Mr. Chair.